So what I'd like to do in this segment is talk about the connections between living with diabetes and mental health issues. I'll anchor this in what we know about normal cognitive experience. And what we know from cognitive psychology is that the normal emotional experience associated with the perception of loss is depression. Depressions are not always pathological, but they can be normal. The normal emotional experience associated with the perception of threat, what if, is anxiety. And the normal emotional experience associated with the perception of intrusion, someone is in your face, is anger. And so it's important for us to understand that these emotional reactions aren't always a sign of something wrong, but can be part of normal experience. And so let me ask this question: what are we really interested in? So when we're trying to promote health, quality of life within diabetes, cardiovascular risk, and chronic diseases, are we interested in a specific mood disturbance, or are we really interested in the overall psychological experience of the individual? And so, which we might label as distress, which is a general concept. So let me ask you a couple of questions to reflect upon. Imagine we gave 100 patients a depression scale. What do you think you'd find? Lots of depression. But if you gave the same 100 people a hostility scale, what would you find? Lots of hostility. If you gave 100 people an anxiety scale, what would you find? And you can see where I'm going here. Lots of anxiety. And that's because depression, anxiety, hostility are highly interrelated. And so here's a way of thinking about distress as a general concept that is tied with the downside, if you will, of quality of life, and that distress can be composed of multiple components. Depression, anxiety, notice the overlap, hostility, notice the overlap. And so we need to be mindful that when patients present in distress, they may not necessarily be depressed or anxious or hostile. It could be a combination of all. And it's important for us because when you think about the lived experience of diabetes from the perspective of emotional distress, there's lots of reasons to be distressed if you have diabetes. For instance, the behavioral demands of self-care can be overwhelming. There are a lot of things to do. There's a lot of work to be done, and people can get overwhelmed by the amount of this work. People similarly can be stymied by the complexity of diabetes management. It involves multiple health behaviors. The demands are constant: no weekends, no vacations, no retirement packages. Diabetes can be unforgiving in terms of the complications. No matter what you do, the disease will progress. No matter what you do, hyperglycemia is unavoidable, and at some point you may risk the experience of complications. And diabetes is plagued by uncertainty. So my point is that there is a lot of emotion that is natural to living with diabetes. So to put it in context, where do we draw the line? And you can see that you would expect that distress can increase. Distress can increase for a whole bunch of reasons with diabetes. And at some point, we're going to make a diagnosis using the DSM criteria of a mental health disorder, depression, anxiety, etc. But it's important, I think, for you to understand the continuity there, that it's subjective distress and functional interference that really define whether or not the criteria of a mental health disorder are met. So I'm hoping that that can be useful. Living with diabetes puts you in risk of several things. There's a threefold increase in the risk of depressions. There is a risk in anxieties, in particular fear of hypoglycemia, fear of going on insulin or psychological insulin resistance, fear of needles, increased risk of frustration and anger that interferes with the patient-provider relationship, and an increased risk of eating disorders in young women. Let's start with the depression and burden. When we talk about burden, I like to think about the depression dimension in diabetes beginning with burden. And I like this question personally because I find that patients can relate to it very, very easily, and the answer they give you is quite informative. The question is, if diabetes were a weight that you carried around in a knapsack on your back, how heavy would it be? a 1 pound loaf of bread, 5 pound sack of potatoes, 50 pound iron anvil, or a 2-ton truck. Assessing psychological burden allows us to be mindful of both health beliefs and distress. Health beliefs are the meaning that the individual attributes to their illness. How do they view their illness? What does it mean to them? And if you probe around that, can you tell me what it's like to live with diabetes? What does it mean to you to have diabetes? How does diabetes affect your sense of who you are in your life? And you allow people to tell their story by probing several times. Then they'll tell you they'll tell their experience, tell their story, and you can become mindful of the burden or the impact that diabetes will have on them by virtue of the model that tells us that seriousness, controllability, personal responsibility, and optimism, pessimism are the key constructs of an illness model that derive health behavior choices and that help us to understand the emotional experience of the individual. So if you view diabetes as a death sentence, you're going to be depressed. If you view diabetes as something that you can't control, then you may well be anxious. Depression involves both disease-specific distress, and we have become able to assess diabetes distress separately from depression. And this is the diabetes distress scale, which has 4 subscales to it, which are really quite useful to us in diabetes. And the diabetes distress scale measures emotional burden, physician-related distress, or the care-provider relationship, regimen distress, and interpersonal distress specific to diabetes. Very useful. And given our sensitivity to depression, it's also very helpful for us to start to tease apart diabetes distress from clinical depression. And again, just to remind you of the stress attached to living with diabetes. Understanding depression also involves an awareness of the phenomena of learned helplessness. Think about people who have the expectation that they're supposed to be in control of their diabetes on a constant basis. So testing 2 or 3 times a day, following a healthy meal plan, taking your medication as prescribed. And what tends to happen is that you have these expectations that I'm supposed to be on top and stay on top. And you see this pattern of behavior. Person tries, fails, tries, fails, tries, fails. But notice that what happens is that over time, the drops get bigger, and then when you go up, you don't go as high up. And after a while, what might happen is if you try and can't do it, burden goes up, you reach a point where you give up. And this is called learned helplessness. And it's a very important psychological concept that, in fact, is highly likely to happen in diabetes given the nature of diabetes. So now what we have is this continuity from burden, distress, learned helplessness, to actual depression. And depression is best understood through the concept of major depressive disorder. We can screen using these 2 questions. Over the past 2 weeks, have you felt down, depressed, or hopeless? Or over the past 2 weeks, have you felt little interest or pleasure in doing things? These are the DSM criteria for defining and diagnosing depression. And you can see that they're very symptom-based. They're not talking about why are you depressed, so you're not talking about your symptoms in the context of your life experiences, but just your symptoms per se. What do you do about depression? And there are lots of effective interventions, from behavioral interventions such as pleasure, mastery, behavioral activation, just getting moving, getting back into a life, focusing on developing improved social supports, problem-solving skills, and medication and psychotherapy, particularly cognitive behavioral therapy and interpersonal psychotherapy. Anxiety is a risk when you have diabetes. There's an increased risk of generalized anxiety, and primarily experienced by excessive worry or somatic preoccupation. And diabetes has a tendency to make you focus on your body in a way in which you're very easily interpreting symptoms as threats. Am I low? Am I high? Etc. There are specific risks of psychological insulin resistance, fear of going on insulin. It means my diabetes is worse. It means that I'm more ill. fear of hypoglycemia, and needle phobias. Psychological insulin resistance is important to understand as a separate concept around fear. It's a perceived loss of control, low confidence in using insulin, seeing insulin as a personal failure, as increased disease severity, and perceiving it as really overall just bad news. One can talk about reducing fear of hypoglycemia by focusing on a behavioral shaping approach, which is to get a safe zone for blood sugars. What do you consider yourself comfortable with? And then desensitizing by not making recommendations based on the ideal, but making recommendations about going from a psychologically safe to a medically safe zone. So if you're comfortable leaving the house between 12 and 14, maybe you could be willing to go to 11 to 13, and then 10 to 12, and then 9 to 11. And you can see how this is a very, very familiar psychological strategy for managing fears, and it can be easily implemented to hypoglycemia. So it fits into what we know around anxiety management strategies, which are based on exposure, self-talk, distraction. These are very important, very useful psychological strategies for managing anxiety. It's important to incorporate the concept of irritability, anger, frustration when you're talking about diabetes because of the nature of this disease. Frustration and irritability is a challenging one for many clinicians because people, really have some taboos about this. They often don't want to get, into this sort of angry or talking about, the frustration that people experience. But living with diabetes is difficult because these individuals become patients, and we're often, inquiring about their behavior in detail. We're making lots of recommendations to them. Anger management is a lot easier than one might think. And I think that one of the problems that I see as a clinician in diabetes and cardiovascular areas is that people avoid the emotional conversations, and therefore it doesn't get resolved. As it turns out, if you allow a patient to vent, that is, if you listen to the patient, tell me how it makes you feel, tell me more, is there anything else that frustrates you, are you done, or do you have more to say, that these is really very, very useful for most people. You can in that way understand, validate. I can see how angry you are. Do you want me to do anything about this? Finally, it's important when you're talking about the mental health issues in diabetes to mention eating disorders and what has been termed diabulimia. And this is when individuals seek weight loss through insulin omission. And usually it's type 1 adolescent females who are at the highest risk. It's not a traditional eating disorder. It's connected. But it's really not about undereating. So there's really a low chance that these individuals are not eating. What they tend to be doing is just omitting insulin. And the binges aren't the same because the binges are much more intentional to drive sugars up in order to put the person in a negative state. And there's not the ambivalence that you see with food in the typical anorexic. Good advice when we're working with particularly young women with type 1 is just to look for elevations and sudden elevations in A1Cs. And I always emphasize in working with individuals who have eating disorders and diabetes that one of the best outcomes is to have a relationship with them in which they're willing to come back and see you. So what I've done in this brief segment is try to introduce the concept of the relationship between diabetes, in this case, and mental health. And I'm really wanting to make 2 points. One is that there are a lot of mental health issues that are normative to living with diabetes. And second, the mental health experience of individuals with diabetes needs to be understood as significant and labeled and diagnosed and understood in a way that can lead to interventions that are helpful. So I hope this has been useful to you. Thank you for your attention.